Good afternoon, everyone. Welcome to the second session of the Commission and ANA's fifth Racism in Nursing series. Whether you've been involved in previous series or are new to this space, we are so excited to be back and hope this interactive learning space is a place for you to find guidance and support. Today's session is one of an 8-part series. You will earn 1.5 continuing education credits for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. This series is brought to you by the American Nurses Association and the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism while within nursing and motivating all nurses to confront systemic racism. The Commission and ANA remain committed to driving systemic change within the profession. The Association's recent response to executive orders affecting diversity, equity, and inclusion underscores its dedication to advocating for inclusive policies and combating structural inequities in nursing. ANA continues to work with Congress and federal agencies to mitigate the impact of policies that threaten progress in health equity and workforce diversity. Please scan the QR code to learn more about ANA's public statement, Protecting Healthcare for All Americans. Before we get started, let's review the ground rules for each of our sessions. Please remember that this is a brave space. Discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger, so please take care of yourself. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your turn to speak. Listen intently and respond thoughtfully. Be present. Limit any background distractions or multitasking. Please take advantage of the virtual features available in Zoom. We encourage you to turn on your cameras, use the chat box or the raise hand features to communicate with the group. But remember to mute your microphone while others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information that you are sharing. If you share a scenario involving a patient, do not provide any personal information in today's call or any of our sessions. Feel free to send a direct message to ANA Practice if you're having any technical difficulties during today's call. Please also note that the chat will be closed during the speaker's presentation. Today's session, Using History to Advance Equity and Justice, will be presented by Dr. Dominique Tobal and a panel of experts, Drs. Margot Brooks Carthon, Karen Flynn, Ashley Graham Perrell, and Margaret Moss. I will now turn the presentation over to them.
Thank you, Dr. Francis, and welcome everybody. It is an honor to serve as moderator for this panel on using history to advance equity and justice. For our panel discussion, I'm inviting our panelists to speak about why the history of racism in nursing is important and how it informs their perspective on contemporary nursing. And we'll begin with Dr. Margaret Moss.
Almost there. Okay, thank you, Dominique. I will focus my remarks from and on an Indigenous perspective. What's past is prologue, to quote from Shakespeare, and no one knows this better than the Indigenous people of what is now the U.S. I will offer 2 points in my time for remarks here to undergird the rest. Number one, the people indigenous to these lands are populations rooted for thousands of years in this place and in orality, where remembering is essential to their very existence, i.e. history. Number two, nursing has been going on in this place for those same thousands of years, but unseen as it didn't fit in the Euro-based roots and acceptance of what is nursing. Contemplating these two things then as Indigenous nurses, by their very nature, have the oral world coexisting with the literal world in ways unfamiliar to most. This is often true of Indigenous patients and communities you may come in contact with. Would you recognize it? Would you know what to do? What can we learn from history vis-a-vis the Indigenous experience and how it's germane to nursing? Why is there anti-Indigenous racism, including within healthcare? And it is stunning to think about what has happened on this continent since contact. American Indians and Alaska Natives suffered literal genocide at the hands of the US government. There was no coordinated effort to stop this, including from healthcare, from nurses and others. It happened over quite a long period, persistent and sustained. The UN Convention on the Prevention and Punishment of the Crime of Genocide came about in 1948, which defined the elements of the crime. There's 5. Outright killing, causing serious bodily or mental harm, inflicting conditions of life to bring about physical destruction, imposing measures to prevent births, and forcibly transferring children. These can each be mapped against the federal Indian policy periods. Nurses know this: relocation, reservation, assimilation, termination, and so forth. These things were actual laws and policy periods meant to get rid of American Indians. I applaud the report's use of some of the elements, such as boarding schools and the medical genocide of sterilization, but the word genocide is not used in the report, in nursing education. I mean, American Indian things are barely in that arena, unfortunately. So to tie in history, the cultural and actual genocide of Indigenous people in Northern North America resulted in historical trauma, which we all carry today. Do nurses know this? Do they know what it is, how to help, what to think about it? This is very deep understanding. And often as I go around and give talks and so forth, people don't even know some of the most simplest facts. If I say, how many federally recognized tribes are in America, how many of you would know? How many are in your state? What are they? What are their names? What are their histories? What are their geopolitical event or anything that you might need to know to take care of them? Everywhere I go, it's very tenuous whether people know or not. So also, did we know that Indians, as called at the time, are included in the Declaration of Independence as merciless Indian savages? So if these are our policies and founding documents meant to get rid of the Indian problem, which was an actual government tagline, how would we expect a quick reversal in healthcare and nursing without a deep understanding? This is why I edited the first textbook of American Indians in 2015 for nursing, and yet nursing education started 140 years before that. So that's sort of stunning. And finally, I had the privilege to work on a report, In Plain Sight. You can Google that, In Plain Sight report, because I think there's a film, addressing anti-Indigenous racism in healthcare, commissioned by the Minister of Health in BC, Canada. As you may or may not know, in Indian country, we say, we didn't cross the border crossed us. And so things happening on both sides are quite the same in many regards. We used to call the border, though, the 49th parallel. We didn't call it that. It was the 49th parallel, but we called it the medicine line, as it was felt that during the Indian Wars and some of these historical things going on, if you could just make it across, you'd be safe. But fast forward to present times, and unfortunately, as noted in the Commission's report regarding settler colonialism, and I hope you all do read that part, it's important to note this is specific to Indigenous populations around the world. One of those things is remove and replace. Remove Indigenous people and replace with the dominant culture and all others to support the dominant culture. So what is the answer for nursing? The answer is to reverse this in nursing education and practice. And what is that? Decolonization, indigenization, and reconciliation. Decolonization, if you reverse the remove and replace, remove some of the content to allow others to come in and correct wrong or harmful notions. Indigenization, we're not saying get rid of Western ways of anything. We're just saying give us some room. And then indigenization is replaced with indigenous knowledge and ways of knowing to help achieve the R reconciliation, which is bringing this population back to where they would have been had genocide not occurred. So I'll stop there because I threw a lot of words and I'll be happy to talk with you all later. Thank you.
Thank you, Dr. Moss. And over to you, Dr. Flynn.
Okay, it's a pleasure to be here. I'm going to be focusing on African Americans in response to the prompt. I begin with the notion that the history of racism is important because race and its consequences of racism has shaped the profession and continues to reverberate the fact that the occupation remains predominantly white. According to the American Association College of Nursing, as of 2022, 80% of the nurses, RN in particular, are white. Also worth mentioning is the fact that from 20 to 22, the percentage of men in nursing also increased from 9.4% to 11.2%. I suspect that that demographic is probably also mainly white. So to understand the current composition of the nursing profession means exploring the centrality of race, not only to those who are racialized as Black or Brown or Indigenous peoples, by looking at the evolution of the profession in the United States. So the development of nursing as a profession for middle-class white women in the US is inextricably linked to Victorian ideals of respectability and femininity, which is connected to white womanhood. And that has culminated in a long history of racist exclusion that has shaped the profession. While white nursing leaders in the United States fought for the development of nursing as a legitimate, respectable, and autonomous occupation vis-a-vis medicine that was predicated on the exclusion of non-white women. The example of African-American women in the South illustrates the length with which white women went to include Black women from nursing. So in the South, folks are familiar with how Black women who wanted to train as nurses were excluded from accredited nursing schools. In the North, even though de jure segregation was not a norm, de facto segregation existed. So let's take the case of Emma Reynolds, for example. Emma Reynolds was a white teacher in Kansas that witnessed health disparities between African American and whites, and she felt that the way to address these health disparities, which are clearly historical, was to decide she wanted to become a nurse. And she applied to every nursing school in Chicago, the so-called promised land, and was excluded. Eventually, her father, who was a reverend, spoke to Daniel William Hales, and subsequently, with some white supporters and Black supporters, led to the creation of Providence Hospital and Training School for Nurses. One of that training school that had a white-only policy was Cook County School for Nurses. Historically, Cook County Hospital and its nursing school had an exclusionary white nurses, white physicians only policy. When we tell the story of Cook County, it's often referred to as Chicago's Headless Island because it was a place for immigrants. What it doesn't tell you, or what no one ever really talks about, is the fact that it had this exclusionary history. So at the center, where I'm the director, we have 6 portraits of all the directors of nursing and a plaque that tells you just how great they were. But again, what our centers and museums fail to tell is that these nursing directors that are on the wall are complicit in their white-only policy in the victimization of nurses and colors. So in the desire to chart the progress of the profession, the history of nurses becomes celebratory, centering white nurses, leaders, and triumphalist narratives, a cultural practice that ignores its racist and messy past. What matters to this occupation was and remains to a certain extent an investment in solidifying its identity and status as an occupation that's primarily white. The history of this history is also reflected in the walls of a lot of nursing schools, and where it centers white nursing leaders, which sends a particular message about belonging. And at this point, I want to switch quickly to this idea of professionalization. And again, we see this history of white nurses dominating in leadership leadership roles in hospitals and nursing schools. And when I attend nursing conferences, academic associations, journals, whether consciously or not, the focus is often on white subjects and whiteness as the norm. So this history of professionalization is nursing. It's a concept that's used to denote the occupational strategies of education or registration that the occupation adopt to maintain control over its work through standardizing the curriculum and controlling admission, all of which had historically impact on African-American nurses, for example. And what's interesting about this idea of professionalization is this concept of professionalism. And I think I have like 2 minutes, 1 minute left, right? So 1 minute. So, I presented a paper last week that I was focusing on Black feminist ethic of care during pandemic. And I gave the example of one of the nurses who I interviewed providing a patient with her phone number during COVID. The response of a friend of mine was that she felt that that was unprofessional, right, for this nurse to do this. So when we think of this notion of professionalization and professionalism, it's rooted in Eurocentric cultures and norms. Because for this particular nurses, and historically, Black nurses, whether they're in Canada or the United States, have seen the work that they do in the hospital, in the clinical site, as a larger struggle for Black liberation. And so when this person questioned this notion of what constitutes professionalism, there's a lack of understanding about the history of Black nurses' struggle for liberation and equity in the profession. We can talk more about this later. Thank you so much.
Thank you, Dr. Flynn. And Dr. Graham Farrell.
Hello, everyone. It is a pleasure to be here with you. So I have been asked this question numerous times about the importance of history of racism in nursing. I've been asked this numerous times as a nurse historian, and I chose purposefully to deviate from my usual answer given the turbulent and challenging times that are among us. Instead, I thought back to my exposure and experiences to healthcare pre and post nursing. And some of the experiences that came to mind were joyous and a little hurtful. It involved rushing my loved ones to the hospital after she suffered a stroke on Christmas Day. It involved the euphoric waves that washed over me as I watched my nephew being born. It involved the day I held my grandmother for the last time before rushing her to the ED during the COVID-19 pandemic. The interesting part of all of these experiences is that whether I was a patient, a nurse, or a loved one, I was always cognizant of my race and the color of my skin. I was always cognizant of the deleterious possibilities that that may have on my health and that of my loved ones. I do encourage us to reflect on our own experiences in healthcare and share it with one another. Ask yourself, when I access healthcare, am I cognizant of my race and ethnicity? And what does that mean? So when I talk about racism in nursing, I don't focus on its history. I focus on its presence because that's exactly what it is, present. It always has been. History, by definition, is the study of past events, which may make it seem as though we're talking about something that no longer exists, something that has been resolved. But now more than ever, we must be clear. We're not talking about a relic of the past. We are and always have been addressing the ongoing presence of racism in nursing. So I'd like us to consider the definition of our profession, the ANA's definition of nursing, the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and the advocacy of the care of individuals, families, communities, and populations. And I will say one of my mentors did make me memorize that definition of the profession. When I consider the current issues faced by contemporary nursing, whether it is the underrepresentation of minority nurses, disparities in access to healthcare education, the disproportionate impact of health crises on marginalized communities, I understand that they all stem from historical injustices. So let's not lose sight of our commitment to social justice. History must be a part of the conversation. It must be a part of our objectives. One of my mentors, Dr. Sandra Lewinson, had that objective. History should be an objective in every course, at least one bullet point. And I've taken that on as well. So what I do is I equip myself with the facts, or as the kids say nowadays, the receipts. I'm armed with the historical investigations and analytical frameworks to interpret those facts and the connection to the issues plaguing our profession. I opened my 2021 dissertation, Color Me Capable, The Rise of African American Nurse Faculty at Lincoln School for Nurses, 1898 to 1961, with a line from Darlene Clark Hines' 1989 book, Black Woman in White, stating that the essential difference between white nurses' professionalization and that of Black nurses was the powerful impact of racism and the concomitant necessity to struggle. As a nurse historian, it is my honor to continue the conversation about the presence of racism. But I will note that I closed my dissertation stating that the power of history is that its exploration uncovers deeply rooted truths of mankind, veiled to those whose influences are superficial, and enlightening to those who dare to question and discover. So history is not static, it moves with us, shaping our presence and guiding our future. And when it comes to addressing history, I want us all to say, ah, with literally 3 A's, ah. I want us to include history to acknowledge its presence. I want us to build awareness of its past. And I want us to forge forward with action. I will say I did share that with my husband, and he said, wow, you nurses really love an acronym. And I said, yes, we do. So we want to acknowledge, we want to build awareness, and we want to forge forward with action. Know that when we talk about racism in nursing, we're not just talking about what it is, we're also talking of what was, but what could be. The struggles of nurses who came before us, their barriers, their resilience, their victories are not confined to the past. They echo in our present and demand our attention as we shape the future of this profession. So this is the weight of history, and sometimes it can feel weighty, right? It can welt the soul a bit, but learn that its lessons persist, and it reminds us that progress is not inevitable, but is something that must be fought for. I look forward to continuing this conversation in our breakout rooms. Thank you all.
Thank you so much. And finally, Dr. Brooks Carthon.
Hi, everyone. It's really great to be with you today. I promise you that Dr. Graham Perrell and I did not share notes, but you will see some topics that overlap, including an acronym. So first, I want to acknowledge that this topic of race and the history of racism in nursing, it can be difficult. It's challenging to talk about racism, particularly in nursing, because as nurses, we are viewed and we view ourselves as nurturers, healers, trusted advocates, and professionals. And year after year, Gallup polls tell us that we're the most trusted profession in the nation. And I believe we've earned that. So it's hard to grapple with the legacy of racism because it's hard to hold both of those truths in tension. But I also believe we're unpracticed, right? We don't talk about racism. And so as educators, we don't teach it. As researchers, we don't include it as a critical explanatory variable. And by failing to address the history of racism or racism contemporarily, I believe it puts us at a decided disadvantage as we claim and aim to address health disparities. Because we know as healthcare providers that what we can't treat what we don't name. So naming is important.
And I view understanding the history of racism as a tool to help us evaluate complexity, context, and causality, because many of the contemporary inequities and health disparities that we see in population and disparities that we see in the workforce have a dotted line to historical roots. But I also believe that the history of racism provides us with strategies. We are not the first generation to face racism in nursing, and unfortunately, we may not be the last. But history and nursing history can be instructive because it gives us an opportunity to learn about nurse leaders and how they fought successfully against racism. So by learning about those histories of Mabel Stoppers and how she helped to integrate the armed forces, and Sylvia Mendez, an activist and Presidential Medal of Freedom awardee, and Mary Elizabeth Tyler, a Black public health nurse that I met in my dissertation who came to Philadelphia, a racially divided Philadelphia, and helped to address tuberculosis disparities. By learning about these histories, we gain tools and strategies, and we walk away feeling empowered as opposed to apathetic. So that's why the history of nursing is important. So to the second part of your question is, how does the history of racism inform my perspective on contemporary nursing? So I'm a health equity researcher. So most of my research actually deals with contemporary health inequities. But history has always framed and colored my work because I've recognized it as a critical root cause to many of the disparities that I see in marginalized communities and in the nursing workforce. And so the nursing workforce is decidedly, it lacks diversity, but also of the nurses in the profession, they're also more likely to experience higher rates of burnout. And so why is that? Why do nurses of color have these experiences? And so we need only look back, because what we're seeing are repercussions of systemic racism and structural disadvantage, whether it be in educational systems. If you look at advanced training opportunities, for example, that were limited for minority nurses, particularly in midwifery, we can see the ways in which nurses of color were not gained or allowed access into specialties such as midwifery, which reduced access for Black and other women of color. And so reducing access to important maternal care is directly linked to many of the maternal health disparities that we see today. And so those are seeds that are sown in our past. We're reaping those harvests in our present. And if we don't name it, if we don't make room for racism and the way we articulate our understanding, then we'll develop strategies that won't work because we haven't identified properly those root causes. So I'll give you another quick example about the history of racism and why it's important. Our team has studied burnout for a long time, and particularly during the COVID pandemic, we did so. And we did interviews, conducted interviews of Black nurse practitioners. We wanted to know about their experiences providing care. And we heard three things. We heard about their passion for addressing health inequities. We heard emotional exhaustion and burnout, and we heard and we heard racism. And so right now, healthcare systems are spending hundreds of thousands of dollars to address burnout, increase retention of nurses, and many of those strategies will not address racism. And so what that means is we're throwing money after bad, and we're not including and we're not developing interventions that deal with the root causes of some of the challenges that we're seeing today. So from a contemporary perspective, naming racism as a root problem helps us to focus and tailor, and learning about those who have done so in the past gives us a window into the future. So as a historian, I'm a futurist, right? Because I believe that those folks, those nurse leaders in the past have given us a window into the future, helping us to provide a roadmap to redesign, rebuild, and repair. That's two acronyms, R's and C's. So thank you. Looking forward to talking to you more in the breakout session.
Thank you to all of you for sharing your expert perspective on the importance of the history of racism in nursing. You've provided all of us with powerful insights that makes clear the need to name, to acknowledge, and to reconcile the history of racism in nursing in order to advance equity and justice in healthcare. And I look forward to continuing our discussion in the breakout sessions momentarily. Thank you, everyone.
Thank you all so much. That was incredible. I'm going to briefly share my screen, which has the breakout room discussion questions on it. Your breakout room facilitators will all have these questions and we'll share them in the room. We will come back to